Hi, everyone. My name is Christina Clayton, and I'm very grateful to be with you all today. I'm a clinical social worker and the program manager of the Northwest Mental Health Technology Transfer Center. I would like to welcome everyone to today's webinar on behalf of the Northwest MHTTC and our partner, the Behavioral Health Institute Training, Workforce, and Policy Innovation Center. We appreciate that the capacity to provide effective telehealth treatment has become an urgent issue in the context of COVID-19. This is the last webinar in our 8-part series with the BHI that aims to support community-based behavioral health providers in Washington in their implementation of telehealth services. We will share how to access prior sessions via the chat so you can view past recordings, see slides, and Q&A sheets as they've been developed. We've structured these sessions so that ample time is dedicated to Q&A and discussion. But first, a little introduction to the Northwest MHTTC. The MHTTC network is a nationwide network funded in late 2018 that is supported by the Substance Abuse and Mental Health Services Administration. Its purpose is to disseminate and implement evidence-based practices for mental health disorders into the behavioral health workforce. Our Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We provide training and technical assistance in evidence-based practices to Region 10, which includes Alaska, Idaho, Oregon, and Washington. We also promote our resources, which are all free, online trainings, and other opportunities nationwide. Broadly, our goals include to ensure the availability and delivery of free, publicly available training and TA, to heighten awareness, knowledge, and skills of the workforce, to accelerate adoption and implementation of evidence-based practices, and foster alliances among diverse communities. Next, we'd like to talk about language. It is our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage everyone to use and champion person-first language, which emphasizes the individual, not condition, diagnosis, or disability. This is a way to demonstrate respect for the person's dignity and worth, and it's consistent with recovery-oriented practices. Also, as a reminder, this session is being recorded, so please be mindful of sharing any confidential information that should remain outside of the session.
Good morning, everybody. This is Melody McKee, the Program Director for the Training, Workforce, and Policy Innovation Center within the BHI, and happy to have you all here today. And just want to express some gratitude to the Northwest MHTTC for their partnership in this series. It's been an excellent experience, and we couldn't have done it without them by any means. Also want to let you know that while this 8-session series is coming to a close, we are going to continue our Friday trainings through the BHI on Fridays from 11 to noon, same time, and you should all be receiving some communication about that shortly. Next slide. We have the same panelists on the call that we typically do, and our today's presenter is Dr. Hilt, and Cara will give you a better introduction shortly. Next slide. Next, we're going to do our poll, our Getting to Know You poll. You're going to see a poll pop up that's going to ask you what type of provider you are. So we have prescribing provider, nurse or medical worker, behavioral health clinician, therapist, case manager, outreach worker, administrator, tribal health or tribal health organization, education or school-based organization, clinical supervisor or peer specialist. We've got about half people have answered the poll so far, so we're going to give it just a little bit more time. It's looking like we've got quite a few behavioral health clinicians and therapists on the line, and some clinical supervisors, nurse or medical worker, couple people from each category. We have some tribal providers on the call and some people from education as well. Okay, so we're going to close the poll. You will need to exit off of your screen for yourself. And then next, I'm going to have Cara Towle introduce our presenter.
Thanks, Melody. I'm delighted to introduce Dr. Bob Hilt, who is going to be speaking today about using telehealth with children and families, and adolescents, which will be very interesting, I think, for all of us. Dr. Hilt is a professor of psychiatry here at the University of Washington, but is mainly based, I think, at Seattle Children's Hospital. He is trained as a general pediatrician and as well as an adult and child psychiatrist, and he's worked in primary care as both a pediatrician and a pediatric hospitalist before his current career focusing on child psychiatry. He is the director for the Partnership Access Line, the PAL line, which is a child mental health consultation service for primary care providers in both Washington and Wyoming. And he also directs the Medicaid Psychiatric Medication Second Opinion Program for Wyoming, Washington, and Alaska, and a Multidisciplinary Team Psychiatric Consult Service in Wyoming, I think all of which is done over telehealth. So he's got lots of he's got lots of telemedicine experience under his belt working with children and adolescents and their families. So turn it over to Bob. Thank you.
Thank you for the introduction. I want to, as it was mentioned earlier, wanted to prioritize time to have question and answer and interaction time. So I have a few slides to go through, but really just sharing a bit of the perspective and experiences of doing telehealth with kids. I'm just supposed to say next slide, and somebody there will advance. So could next slide, please. Thank you. We'll focus on just talking about telemedicine used for kids and adolescents, and I'm going to spend more time really on consenting and privacy issues that come up with kids and adolescents to do Tele-Services. Next slide. This is disclaimers. Information today is provided is not legal advice. It's for informational purposes. For legal advice, you're supposed to consult with your own legal counsel. And information I'm going to be sharing is accurate as of today. Next slide. So anytime we're talking about the use of tele for kids, one of the questions that comes up is there evidence that it works? And the rule of thumb with kids relative to adults is across the board, there's evidence, but less evidence. And at last count, for instance, I'm aware of 7 randomized controlled trials to show that forms of psychotherapy when delivered over tele are on par, roughly on par with what you could deliver via in-person visits. So it's not necessarily superior efficacy, but in terms of acceptability, diagnostic accuracy, treatment outcomes, roughly on par for things like parent training, cognitive behavior therapy, and things like that. When it comes to medication management, something that people will turn to the psychiatrist for via tele, there's not that much out there in terms of unique studies and trials of psychopharm delivered via televideo in comparing to in person. Everybody just extrapolates from the in-person research. So we don't have that much, or just acknowledge unique tele support for kids. Next slide. What can you do with kids via tele? Essentially, most everything you can do in person, short of touching the patient. So there are certain things you do in psychotherapies, for instance, applied behavioral analysis, where you're doing discrete trials where you may be physically touching your patient to kind of help them do certain behaviors or rituals or routines. Certain analytics of kids, for instance, IQ testing, quite difficult to do over televideo because you can't set a set of blocks in somebody and say sort the blocks in a particular order. That doesn't work via televideo. But everything short of touching the patient is fair game. Diagnostic assessments are very easily done via televideo. There's some challenges when you have multiple informants and negotiating that on the televideo apparatus. When a child evaluation almost always involves talking to a caregiver. So Do you have the caregiver and child present in the room together? Do you talk to them at separate occasions? And so you have to think through the logistics of that. So the teleroom where you're dialing into, needs to accommodate more than just one person. And with families, you often have lots of kids and lots of distractions. So trying to plan for and negotiate the multiple informants is one of the steps. There are some limitations of what you can do in the psychopharm arena. I have mentioned here this thing called the Ryan-Haight Act. This is federal legislation that technically, according to the DEA, you're not allowed to prescribe a controlled substance to a patient who you have not at least seen once in person before doing so. The DEA has basically given some informal guidance that they're not really planning to enforce that rule. As long as you're doing good faith care and provision, they were concerned about opiate prescribing over the internet at one point in time. But there is this regulation thing out there that prescribers have to be aware of. And controlled substances means benzodiazepines, things like Valium, or stimulants for ADHD, Ritalin and Adderall. Those medicines fall under the controlled category if you weren't aware. Medical providers often want to have vital signs, height, weight, blood pressure, pulse. It is difficult to do those things. Theoretically, you can have a family who's staying at home for whom blood pressure is really a big issue, order one of those sort of automated blood pressure cuffs and do the best you can that way in a bathroom scale, better than nothing. But then you have to compare against what you already had in your office. And certain physical exam things, like when I prescribe an atypical antipsychotic, I might want to check somebody for cogwheeling, which is a muscle tightness reaction to the antipsychotic. Via televideo, I can't do that. So there are some limitations in there that limit everything you can do. Next slide. For getting a family ready for a telesession, there's a number of things to think of. A lot of this you may know, some of it you may not know. So one thing being having a broadband Wi-Fi connection. American Telemedicine Association, for instance, says greater than 384 kilobytes per second upload speed is the standard to have a good connection. So we have some families who will say, oh yeah, I'll do tele, and then it turns out they're riding in a car somewhere and trying to FaceTime, and it just doesn't work. Really, the idea is to be in a stationary position somewhere, use a device with broadband Wi-Fi connection, and then all of the different connecting systems, such as Zoom, which we're using today, work much better. So holding a phone and walking around with it doesn't create a good a medical visit experience either. So, coach people that need to prop up a tablet or something to have it stationary. We also highly recommend testing a connection before you rely on it for a clinical appointment. You don't want to, oh, everything's been building up. I've been planning for weeks to have this appointment. I only have this hour that's scheduled and the connection doesn't work. Nobody really tested to see whether it's possible to do Zoom on their computer or whatever. So the best practice is to have someone test out the connection before the actual clinical service time. And if you can have administrative people do that ahead of time, so much better for the patient care experience at the time of appointment. Talk about billing if it's going to be different for the family. Most insurances will cover a televisit, but it's not a 100% guarantee everybody does. So, to make mention that, this would be a billed service so that families are not surprised about that later. The confidentiality limits of a home are a problem for kids in some ways. So we have sensitive things that we'll talk about with parents. Asking if the child has ever been neglected or abused in the past is a conversation that a lot of families don't want to broadcast to everyone in their household, for instance. And you may not have recognized this, but the natural thing when you're conducting a telesession is you tend to talk a bit louder. One should not assume that, say, just being in a bedroom of the home means nobody else can hear what's going on. It isn't perfect confidentiality. Kids may want to have conversations that their parents can't overhear. State of Washington, kids 13 and up can consent for their own care. And if they don't want their parents to know something, they don't have to know something. The parents are not supposed to even be able to see the medical notes. So confidentiality is important. And we can negotiate things around that by saying, if they have a family car that's in the driveway where the Wi-Fi still reaches, they could bring their device out to the car and conduct a session there, and it's even more private, as one of the ways to deal with privacy issues during the COVID crisis and connections from home. Having a lot of practices want to have rating scales done before appointments. Having that filled out in advance before an appointment is one way to do that, or to email them back and forth. A very brief rating scale like a GAD-7 could be verbally administered over the tele apparatus, so that would be another potential pathway as well. That's a few of those things. Next slide. Thank you. Some other things to coach families about. You get a better connection signal when there's a relatively plain background. So having the background be a window where there's trees and wind blowing outside, that takes a lot more bandwidth to upload. You can have a jerky connection when that's your background. And it also might wash out being able to view someone's face. So ideal is to have a light from the front and a room where there's minimized distractions. And then, those are just some of the, and I already mentioned about bandwidth and devices. If you're going to be doing telemedicine with someone regularly and they have an older laptop that doesn't have a decent webcam, there are aftermarket webcams that cost about $100 that do a better job with both video and audio. And so like the Logitech C900 something is one of the ones that we had used earlier in our series, but there's a bunch of them available on the market that could help if you're having problems with quality connections with families. Next slide. So consent. There's both consent for care that you normally have, and then an additional level of consent that we recommend for having services occur via tele. The ideal is to have a separate telemedicine consent form that lists out some of the unique choice, confidentiality limits, and the care processes involved with delivering services via tele instead of in person. If it's not practical to do this, doing a verbal consent at the beginning of an appointment is the next best alternative. And if you standardize this, you could use a script to read to someone over the phone, have them verbally acknowledge, yes, I consent for this care, and then you would document that you went over the verbal consent at the beginning of the encounter and got their consent for proceeding. With kids, age 13 and up, they can self-consent, but best practice is really to have a parent or guardian doing the consent for care as well. Regarding the consent for care documents, another sort of in-between strategies, you could email the consent for care document, ask them verbally, have you had a chance to review this? Do you have any questions about it or concerns? And that's a more abbreviated discussion at that point. If some families could actually sign it and fax it back to you or mail it back to you if you have enough time before an appointment. All those are valid strategies. Next slide. Oh, I'm sorry, let's go back one. I didn't actually talk through the provider document note. This is just some sample text at the bottom there. What you might put in your chart. I conducted the encounter from this location to that location via secure live face-to-face video. Patient was located at this and was with this other caregiver. Prior to the interview, risks and benefits were discussed, and verbal consent was obtained. So you can use a phrase like that. Next slide. So on this slide is an example of the kind of script that someone could use for the consent, and any clinic would be welcome to come up with their own terminology. So reviewing, you've elected to receive care via tele, enables us to do the visits via technology, but it may have limitations, including not having a physical exam, being unable to get vital signs, unable to administer standard rating scales and testing, and understanding the risks and benefits. So that's just one of the examples that you could use, and you come up with your own script, and that way you know what's being said every time. Next slide. Another consideration is that teleconnections often fail. I have this problem more with the more rural communities. For instance, a lot of our teleconnections to very rural communities in Wyoming, where the internet connection is spotty for the entire town. We could be halfway through an appointment and suddenly the connection drops. Or we're partway through the appointment and the audio cuts out, but I still have blotchy video connection. What do you do? So having a telephone number that's your backup is a good good best practice to have. What number should I call if we get disconnected? Is there an emergency number in your area if you're working with somebody who has fairly intense suicidality and has the potential to, say, hang up on you after stating, well, that's it, I'm going to kill myself, click. You're left holding the bag. What am I going to do now? You might want to pick up the phone and call 911, but if you do that, 911 connects to where you're at, not where the patient's at. So you need to have a phone number or look up a phone number for emergency services in that patient's area. At the beginning of the video visit, checking with somebody, are you in a spot where you feel comfortable having conversation and discussing your sensitive healthcare topics. If it's somebody who don't know and it's a first appointment, consider asking to be shown a picture ID. And if you have a hospital ID, you can do the same thing and hold it up the screen. I'm Dr. So-and-so. Since you're not in a clinical care building, some people might have a question. Are you really who you say you are? So, addressing that as a routine is a consideration. Confirm that they've got the consent for care and explain how you're going to conduct the encounter. Next slide. Some of the special concerns with kids in tele, some other areas. Consent for care, I already mentioned, being 13 and up in Washington. Whether or not you have a caregiver involved can be a hot topic. Most of the time, with few exceptions, the best practice is to have a caregiver involved with the appointment, with acknowledgement of the appointment, with assistance with follow-up with the appointments. And so, performing an appointment with the parent in the room, or at least connecting to the parent, caregiver before or after the appointment is the best practice. Kids in general adapt really quickly to televideo appointments. It's the parents that are a little more leery. It's like, I don't know about that. But once you get into it, then things go pretty well for the most part with most families. There's a challenge with keeping kids contained in view of the camera, particularly very young children. They will go off somewhere in the room while talking to you in color or play with cars, and you can't see them on the screen. And so that's one of the challenges that will come up. Having relatively quiet activities available for a very young child at a televideo appointment and to be in view of the camera is one of the things you could coach parents about, so that you have a chance to actually see the child as opposed to kind of drifting past the camera once in a while. Having an adult available in the home with cell phone access is really a best practice as well. Again, that scenario with, let's say, an adolescent you were having an appointment with, and they say, I'm gonna hurt myself now, or there's something really risky going on, or you know, they pick up drugs and use them in front of you on the screen. Having an adult that you can call and say, hey, this is what's going on. Can we check on Johnny or Susie here? Would be something you don't want to have to scramble for at the last minute. And then confidentiality, like I mentioned earlier, sensitive topics about trauma and neglect, extended family history that not necessarily everybody in the family knows about and then has to get reiterated over the telephone. All that stuff is a challenge. Next slide. I have on here a list of 3 links for potential resources. The American Academy of Child and Psychiatry has a web page devoted to resources about telepsychiatry. One of the documents on there is a 2017 clinical practice guideline that has a list of published studies on it. If you need to show published studies to somebody in your organization, say it's valid to do this for kids, here's the references for that, or some more detailed advice about some of the areas I touched on right now. There's from the American Academy of Pediatrics, a couple of nice documents that came out with recently, a teleconsult form that can then be edited and adapted by practices, a one-page consent, and a billing sheet for tips about billing practices. Things like using the 95 code or GT modifier in the old parlance to designate the clinical service was delivered via televideo apparatus instead of via an in-person visit. So I tried to go just exactly half the time so that we have lots of time for Q&A. So I'm going to pause there, and this is our opportunity to interact.
Great, thanks very much. We do have one question in the Q&A from Daphne saying, how would you code psychotherapy for young children when parental support, parentheses, proximity, is required? Can we still code 90836, or do we have to code client present with family 90846?
I don't know the answer to that question. That's a good question. I just would go back to the descriptor regulations on each of the codes. I'm not going to be able to give that level of coding advice right now.
Yeah, and we can do our best after this to do a little bit of research and see if we can find an answer to that. And if we do, we'll post it on the Q&A that's associated with this on the website.
It's, coding for, as a psychiatrist, I have it easy in many ways in that I can use what we call the evaluation and management codes, 1 through 5 level E&M codes. And as long as I do a greater than 50% counseling care coordination designation, and that doesn't require, have sub-designations of whether or not parents present. It needs to have the patient present, but not necessarily the parent. So I don't myself typically use the independent psychotherapy codes.
Any other questions? Anybody want to raise their hand and verbally ask a question? I'll ask a question.
Sure.
Do you, you talked about some of the limitations of doing telepsychiatry into the home with children. Are there any anything that you get out of it that you get more by doing tele into the home rather than having them come into the?
Yeah, there are some adolescents that will open up more via televideo than they will in person. It just feels a little bit more, you know, they live in a texting world and appreciate that, you know, 1 degree of separation. And so there's periodically adolescents, it seems that you get more engagement than you do in person. There are home environment situations of information that you receive that you may not get otherwise. So you know, when you go into somebody's home, even via tele, you may learn things you might not have learned with just strict office appointments in that controlled environment. You know, things happen in a home in the course of an evaluation that is more grist for the mill, more information input that you might not have had otherwise. And families, you know, tele is not perfect. Tele can be glitchy, particularly with many of our services getting overloaded in the COVID era. But, you know, in-person appointments have their glitches as well. Somebody gets stuck in traffic, you know, or you know, the schedule doesn't work because they have to go from here to here very quickly. And now they can incorporate an appointment more easily because tele doesn't require them to be on the road as much. So there are some distinct advantages to doing services via tele relative to in-person. I can say also that as a tele provider, when I do appointments back to back all the time with kids and families, I do a little bit more work within the session to be up and engaging and really draw the kid and draw the parent in to the interaction than might be required when you're physically present in the office. And so a lot of people would reflect that if they do tele all the time every day, it can feel a little more draining than all the time every day in-person often appointments, just because of having to be, you know, up and on quite so much to draw people in. And that's a certain, you know, getting used to the platform. And with greater familiarity, you tend not to get as anxious about establishing the provider engagement and interaction. And I think with more experience, it's a little less taxing as the provider.
Great, thanks. We have another question. Are there play therapy techniques that work with teletherapy?
So that's kind of a loaded question in a way, because you know, evidence base for play therapy is not as robust as the evidence base for things like cognitive behavior therapy. And it's all a question of how you do it. The challenge with play therapy, when you're using it in what I would consider the right way, and I'm one of the few child psychiatrists out here that actually had been trained as a play therapist at one point in time, is when you're using it right as a communication tool with a very young child who's not going to be able to verbally interact and verbally play in the way an older child was, and you're using it the right way, it's hard to play with the same toys that the child is playing with. All you could do is get the child to be, you know, be in visual view of the camera, and you could do an audio commentary about what the child is playing with and kind of mimic play therapy. But I'm not aware of people who have done research to show comparability to in-person. It is more challenging.
Thank you. Question from Georgiana Sedler. What do you do if your patients only have a telephone versus a laptop and internet connection? Can you still do a telesession?
In a pinch, yes. It's but it's not the same service. So this is both a billing and clinical care question. In billing terms, nearly all of the therapy and E&M codes that we would use translate to interactive televideo interactions. Telephone-only interactions, there are a few billing codes for those that most insurers don't actually pay for, or if they do pay for them, for instance, I'm forgetting what the codes are now, they're not very significant reimbursement, like getting paid $20 for a 20-minute interaction, at best. So you can conduct a session via the telephone. I think we've all done it. We certainly do it all the time in the past for crisis management, talking to somebody over the phone. It eliminates a lot of the interactive feedback and the nonverbal communication, so it's not as good as a televideo interaction, but it is better than no interaction. So I'm in favor of doing telephone only when you really need to provide the care and there's not an option for televideo. But you have to, on the billing issues, it's not the same thing.
Okay. Thanks. Any other questions from folks? If you raise your hand and you have a question, we can unmute you so that you can have a discussion rather than typing something in. Apologize, I seem to have a lot of trucks going by my window today.
My dog's only barked once, so that's good.
Yeah, very well behaved.
Yeah.
How about, are there any circumstances that really just don't work well? Any particular diagnoses or anything that don't work well over tele?
That's a good question. If you're asked to evaluate somebody with significant developmental or intellectual disability, severe autism spectrum disorder findings, and you don't have, this other person in their life who's there to assist the appointment and provide all of the other verbal information for you. If somebody says, "Oh, just see this developmentally impaired child via tele," and someone will just sort of turn the equipment on who doesn't really know the child, that's an inferior evaluation. But it would be an inferior evaluation in person as well. It is a challenge to keep somebody with a very young developmental level in the screen for any extended period of time. When you're in person in an office, you can be in this room with a closed door, you can have distracting toys, the kid can bounce around the room, but for the most part, they stay in the room where you can see them. With tele, very young children often wander off, and you need to accept that limitation. And then the other thing that concerns me is when I do medication management, the lack of a physical exam. There are times when that is a real problem. Medications I prescribe that would impact blood pressure, pulse, medications that make people gain weight or have physical symptoms, I'm limited in some of what I could do in that setting.
Great, thanks. Any other questions? Melody, did you want to bring up the question that came up from a previous session?
Yeah, thanks, Cara. We did have a question at one point, and it was regarding children who are over 13 who are wanting to receive services without their parents knowing. And do you have any innovative solutions for how to facilitate that via telehealth, especially in a time like this when parents are most likely home with their children?
Yeah, so there's the legal issues and practical issues. Legally, you can see a child 13 and up without parental permission, without the parents being able to, given access to the medical record of the child. As a practical sense, it is difficult for, if a parent says, I want to see that record, and gets the kid to, courses through, all parents coerce their kids to do things like going to school, eating their vegetables, etc. Coerces the child to sign the consent to obtain those records. I think it's best as a caregiver to assume that parents are most likely going to see the medical record. It's just a question of when. It is worth doing a lot of work to try to keep it as separate as possible when there's concerns about parents truly not having the best interest of the child at heart. Substance use, abuse, things like that, settings where we're really trying to keep the sessions as isolated and separate from parents as possible, because parents typically don't appreciate and struggle to appreciate the need to have the kid have their own care. So you can do it legally, but practically, what kind of engagement do you really practically need to have with parents in order for the kid to, be able to come to future sessions, or be able to pick up a prescription at the pharmacy where there's a copay. And if you do independent sessions with the child only, there's a bill to insurance. The parent is getting an EOB, or an explanation of benefits form, sent to them, so they know their child is getting sessions with the therapist. It's there's a lot of practical challenges with keeping things fully hidden from parents. The actual content of the sessions, that's easier to keep more hidden, not just whether or not you have care. I mentioned earlier, the child could sit somewhere else where they're not going to be overheard. I like the practical nature of being able to sit in a car with a computer or tablet or cell phone connected via Wi-Fi to the family's internet, and conduct a session that way in a much more private setting. Ask the kid if there's a room in the house where truly nobody can hear you. Maybe there's a backyard shed or things like that, or the garage, to have things feel more private while still at home. Maybe there's an option for the child to go somewhere else that parents aren't around for conducting the sessions if they're really concerned about parents overhearing what they're saying. And then if you have a particular child that you're working with that that these particular parent concerns, you would question any, you do an "Are you sure?" Before release of records with kids in those sensitive circumstances. So it's a big pontification there. I tend to be on the side of communicate with parents that care is happening in most cases, because that's usually how things end up turning out best for kids. But there are some situations where you need to try to keep things as separate as possible. And some of those strategies would be what I'd use.
Great advice. Thanks for that question, Melody. And thanks for the answer. It hadn't occurred to me all of the ways that parents would eventually find out. So very good points.
Yeah, I had a supervisor many years ago, when I was learning the field of child psychiatry, say, just assume parents are going to see the record. It's just a question of when, not if. Yeah. And, in terms of how you write things down and what it means to work with kids. And kids don't live in isolation. They live in family units. And you typically need some engagement from their caregivers in order to have a good outcome with a child. It's unusual in an older adolescent for whom you are truly independently working.
Great. I have another question. Are there suggestions with suicide prevention for children, adolescents, and telehealth? It seems like this might be a higher risk during COVID.
Yeah, one of the areas of concern I've had, I've mentioned neglect and abuse a few times. Kids don't have mandated reporters around them very much anymore. There's a lot of abuse, neglect reports that schools used to be doing, and kids are not going to school. They're not going to church as much as they would have in the past. They're not going to relatives' houses as much as they had in the past. So a lot of us are concerned that there's a silent spike of abuse and neglect that's happening that we will be learning about as time goes along, as people have isolated. That's a concern. I don't know for sure that that's happening, because there's also, on the other side, families coming together in face of a crisis and putting aside their differences. So it's a concern. That's abuse neglect concern. But your question was about suicidality. The more isolated people are while suicidal, the worse it is for them. Interpersonal connection, talking is the good thing to do while you're having a suicidality, rather than sitting alone in a room. That doesn't help you feel less suicidal. So trying to build connectivity, make sure that you have therapy sessions is one of the concrete things. Encouraging ways of texting, having verbal, kids are social creatures, having opportunities for kids to socially interact with their peers online, Discord, video games, things like that, any way they can continue their social lives. That would all be positive steps.
Thank you very much, and thank you, Dr. Hilt. This was very informative and very timely for all of us. So just want to go to the next slide. How you can get in touch with us. So, not sure how you heard about our webinar today, but there are a variety of ways that you can be in touch with our center. So you can visit us online. Again, these slides will be posted to our page as well. But you can follow us on social media, you can email us, and you can sign up for our newsletter via our website as well. And so just wanted to let folks know how to be in touch. Next slide. And that is the end of our connection. I believe there's a BHI contact slide. I'm so sorry, but we will, there it is. Okay. Sorry if it got out of order, apologize. But there's also a wealth of information on Melody's team's website as well. So that's a lot of good information. You can email them too.
Yeah. And next Friday, we will be holding a session, I think I mentioned, on doing groups over telehealth. And we've had a lot of requests for that. So hopefully we'll have a good handful of people tuning in for that. Unless there are any other questions, any brave souls out there who want to raise their hand and ask a question, give you a couple more seconds.
And Cara, I will add, this is Melody, I will add that also if you go to the BHI telehealth resource website that's listed there on the slide, we have a provider survey that we've deployed to assess ongoing telehealth needs, and we'd love some additional participation with the survey. So if you go, it's on the very front page of the survey to the right under the quick links section.
Thanks. Great. Again, thank you to Dr. Hilt, and thanks to all of you who joined us today and for the questions that came in. And we look forward to seeing you next Friday.
Yes, thank you, everyone.
Thanks.
All right.
Bye. Bye.